When the primary problem is nerve compression, when is a fusion necessary? Or when can you just do a laminectomy or a decompression? Every patient, every different type of problem, every different type of anatomy, and every different situation requires a different approach. And it's really about thinking through that. It's the surgeon's job to think to themselves, which way of doing this is the best for this patient for this particular problem. Spinal stenosis means narrowing of the channels for the nerve roots. That's pretty much all it means. Now, it can happen in two places. One place spinal stenosis can happen is in the center of the spine. So the central canal, this can get narrowed by bone spurs, by something called ligamentum, which compresses the nerve roots in the center. The other place that the nerve roots can get compressed, or the other place we can get stenosis, is in the foramen. This is called foraminal stenosis. And foraminal stenosis is when the side channel for the nerve root, so as the nerve root exits the spine, when that channel, or that foramen, gets narrowed, we call that foraminal stenosis. A big source of confusion for patients, and actually a big debate among spine surgeons in general, is when do you need to fuse for stenosis? Or when the primary problem is nerve compression, when is a fusion necessary? Or when can you just do a laminectomy or a decompression? We believe that a fusion is the better option when the spine is unstable. When I say unstable, I don't mean like, you're walking around and your spine's going to collapse. What I mean is there's some kind of abnormal motion between two vertebrae or two spine bones that over time may lead to a deformity or may lead to further nerve compression. So if we think that nerve compression or stenosis is happening in the setting of some type of instability, in that circumstance, we will usually recommend fusing the spine together. Fusing the lumbar spine can really happen in two different ways. One way is to just fuse the back of the spine together. This is called a posterior fusion. And what we do in that circumstance is we will put bone graft along the back part of the spine, across the facet joints, and these bones on the side, which are called the transverse processes. The other way to get a fusion in the spine, and we're going to talk specifically about the lumbar spine, which is the lower spine. The other way to get a fusion in the spine is by getting bone to grow across the disc space. When we do that, that is called an interbody fusion, literally meaning the vertebral bodies. We're getting a fusion in the interspace, in the disc space, between the vertebral bodies. There are three ways that you can access the disc space, or the interbody space. First way is through the front. This is called an anterior lumbar fusion, lumbar interbody fusion, ALIF. A second way is from the side, called a lateral lumbar interbody fusion, or an oblique lumbar interbody fusion. So LLIF or OLIF, kind of similar ways of getting to the spine. And the last way of getting to the disc space or the interbody space is from the back. And this is called a posterior lumbar interbody fusion, or a transforaminal lumbar interbody fusion. So you got a lot of alphabet soup there. So ALIF, LLIF, OLIF, TLIF, PLIF, right? All of them just refer to different ways to get to the disc space, to get a fusion in the lumbar spine. Now, what are the differences between them? Let's first talk about going from the front, an anterior lumbar interbody fusion, an ALIF. Now, when we go from the front, a lot of times we need a vascular surgeon to get us there, right? So it can be a bit more involved of an approach, it takes more coordination, you need two surgeons. Some places the spine surgeon does it, but a lot of places use two surgeons. And what we do is we go to the front of the spine by moving the abdominal contents over and retracting these major blood vessels in the front of the spine. What that allows us to do, though, is that gives us access to the entire disc space, the entire interbody space. Because unlike when we go from the back, where the nerve roots are there, there's no nerve roots in the front of the spine. So we can get there and we can open the spine up, we can open up this interbody space, we take out all the disc, and then we can replace it with a cage or spacer and bone graft. And then the fusion happens across there, across the cage. So you can see that when I come from the front, I have tons of room to manipulate it. I have lots of room to get out the whole disc. And then I can put a really big cage in there because I have all this space. And what we call that is the cage footprint, right? So when we come from the front, you can imagine that if we're looking at the spine like this, we can put in a cage that covers that whole bone. This is very good when the bones are soft and we're worried about like the bones sinking into the cage, when we need to manipulate the spine in a very substantial way. You know, this is a very powerful procedure going from the front. Going from the side, or the lateral interbody fusion, also gives us a lot of room to put a big spacer in. So when we go from the side, we can also usually put in a big spacer. So from the side though, there is this muscle, it's not on this model, but it's called the psoas. And the psoas limits us a little bit, unlike going from the front. So when we go from the side, we have to get around the psoas, either go through it or go in front of it. But then we can a lot of times put in a pretty big spacer. Not as big as when we put in from the front, but again, when we come in from the side. We also don't tend to release the spine as much when we go in from the side because the window is smaller. So we simply just don't get as big of a release. So you can't usually manipulate the spine as much when we go from the front. Now again, these are all, generalities, and there's plenty of exceptions to everything I'm saying. Now, when we come in from the back, this requires a little more manipulation of the nerve roots, because you can see that if we're trying to get to the disc, which is right here, right? So we go from the back to try to get to the disc space right here. Now remember, we're getting to the disc space so that we can get a fusion between the two vertebrae, but the nerve roots are in the way. So when we go in from the back, a lot of times we'll have to remove a joint. For example, the facet joint. So we might remove the facet joint, and then we have to retract these nerve roots, and then we can put in our cage. Or first we remove the disc material, put in bone graft, and then we can put in our cage. Now you can just see, just from looking at this, that we can't put this big cage in from the back, right? That's not gonna work. We can't move the nerve roots enough, or if we did, it probably wouldn't work out very well. So a lot of times when we come in from the back, we have to put in a smaller footprint cage. So the size of it may be something like this. And when we think about that footprint, we can see that it doesn't quite cover as much as when we go in from the side or from the front. What we do is, again, we retract the nerve roots, and then we push this cage in from the back, just like that. I think that if there's one thing I want you to leave this video from, I'm not saying that there is one way that's better than the other. What I'm saying is that every patient, every different type of problem, every different type of anatomy, and every different situation requires a different approach. And it's really about thinking through that. It's the surgeon's job to think to themselves, which way of doing this is the best for this patient for this particular problem.